Hello everyone, welcome back to my channel, and today's topic of discussion is going to be on Hydrops fetalis. Somehow this topic kept on catching my eye, so I thought, alright, I'll take the class. Suppose you get this question and I have not taken, then I will feel really guilty. Alright, so what is Hydrops fetalis? It's the presence of excess extracellular fluid. Note that it is extracellular fluid in more than or equal to two body compartments. So what are the body compartments? That should be your next question. The body compartments are your pericardium, pleural space, peritoneum, that's your ascites, and your skin. In skin, more than 5 mm of fluid collection. So these are the body compartments in which excess extracellular fluid can collect. And if it is going to collect in two or more compartments, then it is called as Hydrops fetalis. What is the incidence? 1,700 to 3,700 pregnancies. That is the incidence of Hydrops fetalis. What could be the cause? What is resulting in this fluid accumulation? We will see the why in a moment. Let's see the causes. Broadly, they can be classified as immune and non-immune. Immune is secondary to immune destruction of RBCs, which is the case in RH incompatibility, where the mother is RH negative, whereas the fetus is RH positive. The mother is previously sensitized, resulting in destruction of RBCs, causing anemia, cardiac failure, and Hydrops fetalis. But with the advent of your immunoglobulin, the RH incompatibility has come down as a cause for immune Hydrops fetalis. So more and more we are seeing non-immune Hydrops fetalis. So what are the etiologies? This is a table directly taken from your Cloherty 2021. The most common cause is cardiovascular. So most common cause of non-immune Hydrops fetalis is cardiovascular causes, nearly 20%. The typical causes are hypoplastic left heart and Epstein's anomaly. Any arrhythmias, it can be bradyarrhythmia or tachyarrhythmia, does not matter. So these three things you should remember. Second most common cause closely following cardiovascular is idiopathic, nearly 20%. So 20% cardiovascular, 20% idiopathic. Following that is chromosomal. Chromosomal problem with lymphedema or newborn presenting with isolated pedal edema, lymphedema. If these sorts of questions are asked, the first syndrome that should touch your mind is Turner syndrome. Okay, Turner syndrome results in non-immune Hydrops fetalis. Others are trisomy 21 and trisomy 18. Hematological. See, RH incompatibility came down, but any other hemolysis that can cause anemia can still result in Hydrops fetalis, no? So what can cause in utero hemolysis? It is thalassemia, alpha thalassemia, not beta. This alpha thalassemia. Suppose without hemolysis, can there be anemia? Yes, there can be anemia if there is a hemorrhage to the mother, if there is a feto-maternal hemorrhage. Okay, so these two causes in hematologic you should remember. Then lymphatic problems obviously should result in edema. So any congenital lymphatic dysplasias, yes. Infection, one infection that you should always be looking for is parvovirus. Alright, so Hydrops fetalis torch profile you will anyway send. You will do a workup for CMV. So that's a given. But parvovirus is something you should keep in your mind. Okay, so parvovirus results in Hydrops fetalis. Other virus that you should remember is your adenovirus. Adenovirus causes Hydrops fetalis by causing a fetal myocarditis, not affecting the, see, parvovirus affects your hematological system. Your CMV affects your vessel wall, causing vasculitis. Your adenovirus causes fetal myocarditis, resulting in Hydrops fetalis. Though all these are infection, each of them has a different pathophysiology causing anemia. Causing anemia, causing Hydrops fetalis. I'm sorry. Thoracic, any thoracic mass, anything that raises the intrathoracic pressure is going to decrease the venous return. Decreased venous return will result in increased interstitial fluid shift. So that results in Hydrops fetalis. So think of whatever mass can happen in the thorax. It's a congenital cystic adenomatoid, pulmonary airway malformation, diaphragmatic hernia, sequestration, any pleural collection, hydrothorax, chylothorax. So those can result in increased intrathoracic pressure, resulting in hydrops fetalis. Then syndromic Noonan syndrome, wherever Turner comes, Noonan also follows. Right. Urinary tract malformation. These are all minor causes. Inborn errors of metabolism alone, I would like to concentrate upon. Just two things you remember. Lysosomal storage disorders can present as non-immune hydrops fetalis. Similarly, congenital disorders of glycosylation, CDG. So, lysosomal storage disorders, congenital disorders of glycosylation can present as non-immune hydrops fetalis. So this is the common etiology. So you will remember cardiovascular, idiopathic, your chromosomal, hematologic, lymphatic dysplasia, infection. You can also use the Tim gun method. All right. So that's I leave that up to you. Whichever is comfortable for you, you can use. What's the pathophysiology? So you saw the etiologies. How do those result in fluid collection in the extracellular space, especially the interstitium? So for that, you need to know the Starling's forces. So this is something that you have been reading from the physiology days, right? So this is your blood vessel. This is your interstitium. What pushes things out is hydrostatic. What holds on to things is oncotic. Oncotic, எனக்கு வேணும். தமிழ்ல எனக்கு means me, myself. So oncotic எனக்கு வேணும். Oncotic says I want it. Whereas hydrostatic says hydro go, hydro go. Alright, so hydro pushes things out. So in vessel, if hydrostatic force is more, it pushes fluid into interstitium. In vessel, if oncotic pressure is less, then it cannot hold on to things inside the vessel, so the fluid leaks out. Correct? So this is how you should remember easily. So keeping this in mind, think of things that can cause fluid accumulation in the interstitium. What should happen normally? Through arterioles, some fluid will come into interstitium, and when venule comes, this interstitial fluid should go back into the vessel, right? But it is not going back to the vessel. So what could be the possible causes? So things that should transmit the small lymphatics may not be working well. So it's an anatomical problem like in case of a Turner's or a lymphatic dysplasia. Suppose anatomy is fine, but the physiology is a problem. Too much pressure in the vessel is not allowing the fluid to come back in, or there is nothing holding the fluid inside the vessel, making things leak out. So those are all functional problems. Anything that increases the back pressure in the venules, anything that increases the right atrial pressure can result in your fluid leak. So suppose there's anemia secondary to parvovirus. That can result in a hydrops fetalis. Any cardiac problem that increases the right atrial pressure. It can be arrhythmia. Arrhythmia can be tachy or brady. Any congenital heart disease like your Epstein's anomaly or your hypoplastic left heart syndrome. So that can result in your hydrops fetalis. Anything that increases intrathoracic pressure makes the venous return difficult. If venous return is difficult, your pressure in the veins increases, your hydrostatic pressure increases. If hydrostatic pressure increases, fluid leaks out into the interstitium. Suppose nothing is wrong, your hydrostatic oncotic pressures are fine, your interstitium is also fine, but vessel per se is leaky. Suppose there's a vasculitis secondary to CMV, then yes. Suppose CMV has affected your liver, assume. So in that case, what happens? The synthetic function of the liver comes down, right? If the synthetic function comes down, what goes down? Your albumin. Albumin is the main determinant of your oncotic pressure, right? So if albumin goes down, your oncotic pressure is down. So there's nothing holding the fluid inside the vessel. It leaks back into the interstitium. So these are all the pathophysiology of your hydrops fetalis. How are you going to evaluate a child? So suppose a mother is coming to you during pregnancy with an ultrasound report or oral report that says the baby is having hydrops fetalis. What are the things you should be asking her? You will ask for consanguinity because genetic diseases, inborn errors of metabolism, most of them are autosomal recessive. If she is consanguineously married, then the probability of that being the cause increases. Blood type you will still ask, because in our country where they may not have adequate prenatal checkups, you still get to see here and there RH incompatibility induced hydrops fetalis. So you will still ask for blood type of mother and father. You will ask for previous sibling who was who was stillborn or who was born with hydrops fetalis, so that it will give you a clue about lysosomal storage disorders. Exanthematous fever, you will ask for history of infection in the mother. It can present even without fever, just a plain exanthem. It can present just with a mild fever and arthralgia rather than an exanthem. So it can present in any way. So it's important for you to ask adequately about any sort of fever, any sort of rash, any sort of joint pain that might have come and gone, and they might have thought it as very innocuous. Ultrasound finding. So after asking at least these basic histories, you will ask for ultrasound. What are the things you are going to check in ultrasound? Most of the hydrops fetalis are associated with polyhydramnias. So polyhydramnias is defined as more than 8 centimeter in the deepest vertical pocket that you record, or amniotic fluid index of more than 24. Associated with polyhydramnias, you will look at placental size. Placentamegaly is commonly associated. What is placentamegaly in second trimester if there is 4 centimeter thickness, or in third trimester if it is 6 centimeter, then it is called as placentamegaly. Then you will look at the baby. Now you saw the mother in ultrasound. Now you saw amniotic fluid, you saw placenta. Now you look at baby. See if you can find some cause from the ultrasound. What are the things you will be looking for? You can try to look at fetal echo to look at any cardiac malformation, rhythm problem, right? You can also look at the fetal ultrasound to look if there is a mass, thoracic mass, a teratoma, a CPAM. It can be anything. So chylothorax. So that you will look for. Dopplers, you will look at middle cerebral artery velocity. If middle cerebral artery velocity is more than 1.5 multiples of median, then it gives you a clue that anemia could be the cause for this non-immune hydrops fetalis or immune hydrops fetalis. Okay, so these are ultrasound findings to evaluate the cause. Ultrasound findings to evaluate effects, what you will be looking at. You will be looking for pericardial effusion. You will be looking for pleural effusion. You will be looking for ascites. You will be looking for skin edema. Buddha sign where there is a scalp edema. So that scalp edema will look like a Buddha who has attained enlightenment. So that's a Buddha sign. So these are all consequences that you'll be looking for in your ultrasound. Then what else? Prenatal evaluation. If these findings you're looking for in the mother, you found that in ultrasound there was polyhydramnias, placentamegaly, then you saw that the baby's echo is looking fine, normal, there's no mass in the echo, there's no rhythm abnormalities in the echo. But still you're not sure as to why this child is having hydrops fetalis. You can go ahead and do further prenatal evaluation in the mother. So you can do an amniotic fluid analysis to look for viral markers. You can look for karyotype. You can look for chromosomal microarray. You can do an MRI to pick up things that were not picked up via ultrasound. So MRI can give you a better fetal anatomy. So with all this in mind, a small approach was given in Cloherty, which I found very nicely, அழகா இருந்தது பார்க்கறதுக்கு. So fetal hydrops on initial ultrasound, you are doing a MCA Doppler and echocardiogram and you found a rhythm abnormality. So in that case, treat. You will treat the mother, not the baby, because baby is still in utero, right? So you'll treat the mother with digoxin and you will follow it up with either flecainide or sotalol. Suppose you saw that it was a twin pregnancy and there's a twin transfusion happening, then you will consider laser photocoagulation. You will refer for laser therapy. Suppose in the ultrasound you found that there was a solid thoracic mass, then you will refer for fetal surgery. Suppose there is just a unilateral pleural effusion or a cystic thoracic mass with mediastinal shift. To relieve the intrathoracic pressure, you can do a thoracoamniotic shunt. Suppose these are all not the causes. Then you will look at the MCA Doppler. How fast is it? Is it more than 1.5 multiples of median or less than 1.5 multiples of median? If it is more than 1.5, that means there is an anemia. What is the anemia due to? Is the anemia due to an infection like parvovirus, or is the anemia due to a feto-maternal hemorrhage? Then you will look at Kleuher-Betke test. Is the anemia because the child is actually having a hemolysis? You will do an antibody screen. If any of them is positive and you found that anemia is the cause for child having hydrops fetalis, the treatment is easy. No, you can just give an intrauterine transfusion. Correct? Huh? Suppose anemia is not the cause. Now again you're in soup. You have not found the common causes. No. Then you will try to look for zebras. If you're not able to find horses, try to look for zebras. So you will do a workup for syphilis. If that is positive, you'll treat the mother with penicillin. Suppose syphilis is negative. Then ask for further history. Ask if there was a previous sibling, previous hydropic offspring, or if there's a history of consanguinity. If that is positive, then you can look for enzyme assays for these disorders which can present with Hydrops fetalis. What are they? Niemann's, Ullmann-Pick, Faber, mucolipidosis 2, multiple sulfatase deficiency. If that history is not there, you will go ahead and you will do karyotype fish analysis. You will work up for infections that can result in Hydrops fetalis, amniotic fluid mucopolysaccharide and neuraminic acid levels you will do. And you will look for all sidase workup, glucuronidase, glucosidase, galactosidase. So you will culture amniocytes and you will try to look for these enzyme levels. Basically, you will be looking at genetic disorders and inborn errors of metabolism. In case your common causes of Hydrops fetalis are ruled out, including your infections. Clear? Acha, so we will go through this once again because this is very important. If you are able to find a arrhythmia problem, treat it. If you are able to find a mass problem, then relieve the pressure by an amniotic shunt or fetal surgery. If you find that it's a twin problem, then laser photocoagulation. If it's an anemia problem, try to find the cause for anemia, but treat with intrauterine transfusion. If anemia is not the cause, try to rule out intrauterine infection. If intrauterine cause are negative, then do a genetic workup, do a inborn errors of metabolism workup. Ivulada workup for Hydrops fetalis before the baby is born. What do you treat the baby with? You saw that in the flow chart itself. If it's a parvovirus or anything that results in anemia, you will treat with intrauterine transfusion. So what they found was in studies, if the child was treated or if the fetus was treated with an intrauterine transfusion, 85% of them survived. Whereas if they were not treated with a transfusion, none of them did. So transfusion definitely helps. Then if it is going to be intrauterine infection, if it's a syphilis, treat the mother with penicillin. If it's a toxoplasma, pyrimethamine sulfadiazine along with folinic acid, you will give to the mother. If it's adenovirus, it's secondary to fetal myocarditis, you will give maternal digoxin to stabilize the fetal myocardium. See, syphilis, even though you treat with penicillin, the Hydrops resolves, the neurodevelopmental outcomes may not be that great. So just because you have treated with penicillin does not mean everything is fine. If it's a cardiac arrhythmia, then give maternal digoxin followed by flecainide or sotalol. Which cardiac arrhythmia in the fetus cannot be helped by treating the mother? We discussed this in one of our previous classes. Which cardiac arrhythmia or which fetal cardiac arrhythmia cannot be treated? There's no treatment for it. The answer is pause, think. If you're not able to find, then play. All right. So it is congenital complete heart block. Complete heart block, secondary to maternal SLE, anti-Rho, anti-La antibody. Remember, we discussed this in one of our previous sessions. Okay, right. Then if it's an intrathoracic mass, then thoracoamniotic shunt fetal surgery can be done. If there's a mediastinal shift, then maternal steroids have shown to shrink the size of the mass, relieving the intrathoracic pressure. So twin transfusion, then laser photocoagulation can be done. Neonatal management basically is your resuscitation readiness. You need to have at least 2 to 3 personnel ready. You need to be ready for emergency procedures like, pleural fluid drainage, then pericardiocentesis, then ascitic tap. Because only if you relieve that pressure, the baby will be able to, have a better chance at survival. Then ventilation needs to be proper because especially skin edema and pleural effusion are going to be deterrent to your effective ventilation. So you need to adjust your ventilation settings accordingly. Hemodynamic stability, vaso active agents will need to be given to these children because their cardiac contractility may not be that good. Inotropic agents will be needed. Fluid management is very, very important because the baby may weigh 4.5 kilos, but the dry weight may be just 3 kilos or 2.5. So, idea is for you to know the gestational age, calculate the 50th percentile weight for that gestational age, and calculate fluids for that amount. So, if you want to give 60 ml per kilos, the 60 ml per kilos will be for the 50th percentile weight for that gestational age, not the weight that you are doing for the baby. Hematological management, since many causes of hydrops fetalis are with anemia, you will need to give adequate PRBC transfusion to make sure the oxygen delivery happens to tissues. That's it about your hydrops fetalis. Hope this was simple. We covered multiple questions in this. What questions can be asked? I'll tell you. They can ask directly non-immune hydrops fetalis. Okay, NIHF they can ask. Or they can ask just about the etiology. All right. They can ask evaluation. Or they can ask prenatal management of hydrops fetalis. So multiple ways they can ask the same question. So you need to modify your answer accordingly. We have covered 3 to 4 questions in this one lecture. Okay, so all the best for your exams. Hope this was useful to you. Subscribe to my channel if you have not done it already. I think it's been a long time since I told this statement. Illa? So subscribe. If you want regular notifications, press the bell icon next to your subscription button. So that will give you instant notification whenever I post a video. Share this among your academic groups if you found this useful. All the best for your exams.